Thank you. I'm going to present the data that we presented at the ESC, and in addition provide some additional data from sensitivity analysis that came up when we were in review with the paper. Pleased to say both the design paper and the primary outcome data now published in the Lancet this week with an editorial which was, I think, quite complimentary about the study and its potential impact. So the background is that resistant hypertension, as we heard very eloquently at the beginning of this meeting from David Colquhoun, has been defined as uncontrolled blood pressure despite treatment with maximum tolerated doses of 3 blood pressure lowering medications, which would usually include a diuretic. And international guidelines actually in many ways have supported this study in the sense that they now concur that the 3 blood pressure lowering drugs should be usually an ACE inhibitor or an ARB, a CCB, and a thiazide-like diuretic, which was exactly the design that we had come up with in advance of that being a consensus across the world. Now, the prevalence of resistant hypertension is reported to be approximately 10% of people globally. This would equate to about 100 million people, so this is not an insignificant issue. And these patients are at especially high risk due to long-term exposure to poor blood pressure control, and the fact that many of them have other comorbidities which characterizes this condition. Now, interestingly, when we designed the study, and still today, before we published the results, optimal drug treatment of resistant hypertension has remained undefined. Just before we published the results, and in many ways helping with our research in context section for the Lancet, a meta-analysis was published in the American Journal of Hypertension, which looked at all of the trials that have been done with aldo receptor antagonists and concluded that with spironolactone being the main drug, the mean dose of 25 milligrams daily, this was an effective treatment potentially with a mean clinic blood pressure reduction of about 24/8 millimeters of mercury, and in 2 studies, a sub-study looking at ABPM, 9/3. But I would emphasize these were looking at trials, not the observational data, and there were only 3 randomized controls in this analysis in the whole world literature, which comprised 134 patients in total exposed to drug versus placebo, as well as open and observational studies that were also available. But there had been no randomized controlled trials directly comparing spironolactone with other blood pressure lowering drugs to determine whether spironolactone is in fact the most effective treatment for most patients with resistant hypertension. Now, the other thing that was interesting in this study, and we have a lot of data still to look at, or we've looked at, but we haven't yet got to a point of presentation or publication, is that the pathogenesis of resistant hypertension is poorly defined, and prior studies have suggested excessive sodium retention, despite the fact that we're using background diuretic therapy, may be responsible for much of this treatment resistance. And therefore, the idea that plasma renin, which is inversely related to sodium load, could provide a means of personalizing treatment if we found that different drugs were better in different patients in this particular study. So our hypothesis was that resistant hypertension is predominantly a sodium-retaining state, and that it's characterized by an inappropriately low plasma renin level despite treatment with A plus C plus D. And that further diuretic therapy with spironolactone will be more effective at lowering blood pressure than alternative treatments targeting 2 different mechanisms. Firstly, a beta blocker, bisoprolol, which will provide beta-sympathetic blockade, but also renin suppression, and doxazosin MR, which would block the alpha sympathetic system and provide additional vasodilatation. The plasma renin level that was measured at baseline whilst patients were already treated with A plus C plus D will be inversely related to the response to spironolactone we predicted. And this is the design. And actually the design had some very important features because it allowed us to directly compare the best drug for each patient, which wouldn't be possible with a parallel group design. So a double-blind, randomized, placebo-controlled crossover study. Patients screened for resistant hypertension, as many of you involved will remember, quite difficult population to identify because of the rigorous criteria. Using home systolic blood pressure to define hypertension, excluding white coat, using directly observed therapy to exclude non-compliance with treatment at baseline, and also throughout the trial using other strategies to evaluate compliance. After a 4-week single-blind placebo run-in on background treatment, which was usually A plus C plus D, and the measurement of plasma renin at baseline, the patients were randomized to one of 4 12-week treatment cycles: spironolactone 25 to 50 milligrams a day, doxazosin 4 to 8, bisoprolol 5 to 10, or placebo, which also was a very important addition to this trial, and we were pleased that we were able to get that through the ethics committees. Each cycle was 12 weeks, with forced titration from the low to the high dose at 6 weeks, and no washout period between cycles. And we measured home systolic blood pressure at 6 weeks and 12 weeks, and we asked them to do it for 4 days prior to the clinic visit, and they needed a minimum of 6 readings to provide a valid average, although we took up to 18 readings as part of the analysis. And in addition, and I'm not going to present the data today because we've only had a preliminary look at this, we ran the patients out on open-label amiloride, partly because we had to have something to give them while we're waiting for the rest of the patients to finish the trial. But this also provided an opportunity to look and see whether amiloride might replicate the benefit of spironolactone if spironolactone was seen to be the most effective drug. Now, we took statistical advice, and actually I think this was a clever move of having a hierarchical primary endpoint, the first component of which was the difference in average home systolic pressure between spironolactone and placebo. And only if that was significant could we move to the next, which was the difference in home systolic blood pressure between spironolactone and the average of the other 2 active drugs. And if that was significant, we could look at the difference between spironolactone in each of the response to the 2 active drugs. We screened 436, 88 were excluded, 13 who took no study drug, 335 were randomized, 21 had no follow-up data for any drug, and therefore the intention to treat analysis involved the 314 with any data to analyze. And those are the numbers that actually completed a cycle on each drug. It doesn't add up to 314 because, of course, some took only 1 or 2 cycles rather than all 3, but I'll comment on that in a moment. And 230 patients, remarkably, completed all 4 treatment cycles. It's incredible to have achieved that in a year. These are the baseline demographics. Mean age 61, predominantly men, weight 93 kilos, home systolic blood pressure 147.6 over 84, clinic 157 over 90. So these were significantly hypertensive despite their background treatment. These are, you can see their renal function was reasonable. You were excluded from this trial if you had an eGFR below 45, and we had about 14% diabetic. So this was the primary outcome. First component, spironolactone versus placebo, home systolic pressure change minus 8.7, highly significant. Spironolactone versus the average of bisoprolol, doxazosin, minus 4.26, highly significant. And spironolactone versus each of the other 2 drugs, again, a highly significant response. And all of this is adjusted for baseline variables using a least square means approach. These are the actual achieved blood pressures in this trial. You can see, and these are home systolic readings. Remember, the upper limit of home systolic at the moment is defined as 135. So pretty good control in the vast majority of patients, but clearly vastly superior reductions in blood pressure with spironolactone. This is the primary outcome presented graphically. And you can see clearly that spironolactone did really well. And that line that goes across represents the 135 control line for systolic blood pressure on home average. You can see pretty much everybody got there, pretty close to. And those that didn't were only a few millimeters of mercury above that level. These are the secondary outcomes now, and this is clinic systolic blood pressure, so many people will be more familiar with looking at this type of result. I ask you, first of all, to look at the bottom panel, because this is the typical fall in clinic blood pressure that we saw with spironolactone. And this is entirely consistent with the data that is from the meta-analysis looking at clinic blood pressure, and indeed the data that was published in observational data from the ASCOT study. This is doxazosin, this is bisoprolol, this is placebo, and you'll notice that the placebo effect on clinic blood pressure is quite large in these patients. So Gordon was wrong. Measuring home blood pressure was incredibly valuable in this study because it allowed us to differentiate and remove this very large placebo effect from the outcome. But again, all of these are very highly significant data on clinic blood pressure as well. Now, the other interesting thing is there was a clear dose response to spironolactone. consistent with our hypothesis that sodium retention was driving this state, but also suggesting the possibility that we may not even yet be at the top of the dose range, and that maybe the few that didn't get below 135, we might have got there had we used even higher doses of diuretic to treat these patients. There wasn't anything like the same kind of dose response with the other drugs, which is also important in terms of the crossover effect, because again, it's unlikely we would see that, but you'll see evidence that we didn't anyway in a moment. These are the blood pressure control rates stringently defined according to 135 systolic pressures on home averages. I don't know why that's jumped up. I should say the control rates, the levels of control in our study were the averages of the blood pressure in the 6-week and the 12 weeks. So we actually pre-specified that we'd use all our blood pressure readings on treatment, even the low and the high dose. So in many ways, we're probably underestimating the achieved blood pressure in some of these patients, but I'll show you some data in a moment that confirms that. These are the serious adverse events and withdrawals throughout the trial. I must say, I was really surprised, partly because of the popular perception that spironolactone is associated with problems. We didn't see any significant differences between the drugs in terms of serious adverse event rates. Now let me show you some sensitivity analysis, which we haven't yet presented, but are in the extensive online appendix in the Lancet. And these were in response to some of the comments that we got in review. So this first sensitivity analysis of the primary outcome looks at the home systolic blood pressure only using the values at the 12 weeks. So in other words, not using the low dose, just using the highest dose. And as you can see, there's an even greater effect of spironolactone to reduce blood pressure when you just use the home systolic blood pressure at the end of the treatment cycle. And again, this was highly significantly different to the other components of the primary outcome. What about patients who completed every cycle? As I've said, remarkably, every patients completed every cycle in 230 cases, which is incredible. And this allows direct comparison in every single patient of the best drug. And we can see here again, spironolactone is the clear winner. 230 patients in completing all cycles. Another concern was expressed in our review, or maybe not everybody took A plus C plus D, and that's true. Some people took other combinations of therapy because they weren't tolerant of some of these other components that were recommended as the primary treatment. But we had 216, which is still a very large study in a crossover study, that did take A plus C plus D at baseline. And again, we see an identical result. No evidence that there was any difference in outcome, whether or not you were on A plus C plus D or a variation of it. Then the next criticism. Well, this design is great, it allows you to compare different drugs, but of course you'll see a crossover effect. This might confuse the interpretation of data because we didn't have a washout between cycles. Now, we argued, and when we looked at that, we talked amongst ourselves when we were looking at the data, if anything, the washout effect phenomenon would probably underestimate the benefit of spironolactone because the other drugs were likely to benefit from a washout effect of spironolactone because spironolactone was a diuretic and the other drugs acting on a background of prior diuretic therapy may have got some advantage. But we came up with this clever way of actually addressing this head on, effectively creating a parallel group design within the study by only analysing the data at the end of the first cycle. So the patients, some of the patients got doxazosin, some Spiro, some bisoprolol, some placebo as their first cycle. So if you just look at the drugs on first cycle, there's no crossover, and these are the results. Highly significant, again, in favour of spironolactone, and actually emphasising the dose effect of spironolactone. The final bit of the design, which was slightly unusual, but in many ways a necessity, is, as many of you will remember during the trial, we were running into real problems with drug supply because we had encapsulated the drugs throughout the trial, and they had a shelf life of only 1 year, which wasn't quite clear why, and there was an issue. And we decided for the last 100 patients, as this was becoming really problematic, that we would abandon the encapsulation of the drugs and allow us to do in-trial comparison of whether it makes any difference at all, whether these patients are blinded or unblinded, particularly as we are doing a crossover trial where every patient would get every drug anyway. And here's the data, and I think it's quite important data. The solid bars are the results during the blinded phase of the trial, and the last 100 patients in the hatch bars who got the drugs open label. And clearly, there's no difference. In terms of the blinded versus open label, adjusted for baseline, no difference. And for heterogeneity or interaction, no evidence of any difference. So we wasted a lot of money on blinding, I think. £200,000 plus to put something in a gelatin capsule. Next, of course, safety. And serum potassium at the end of each treatment cycle. This is a really nice diagram. Just let me explain it. This is a stack diagram, so basically each drug is just stacked on top of the other to show distribution. And this is the end of the trial. So you can see spironolactone in red trending towards having slightly higher potassiums than, for example, some of the other drugs. And when we get down here, where we might get a bit more concerned about potassium, we see predominantly spironolactone, but very low levels of potassiums in this range. So, for example, just a change in serum potassium on spironolactone was from 4.1 to 4.5, so about 10%, but I would emphasize we're only looking here at patients with EGFRs above 45. So we have no data on safety in people with worse GFRs, but there were only 6 patients down here that developed a potassium between 6 and 6.5, and none of them were there any issues. And basically, we made adjustments to the treatment. So this, at least in this study, was a very safe treatment associated with no major problems with potassium. EGFR is another issue that often comes up, and I think this is a really important result that could only be got from doing a comparison with other blood pressure lowering drugs. So this is a stack diagram for EGFRs, so you can see where all the EGFRs are distributed. And I guess you could say that there's a trend towards slightly lower EGFR on spironolactone. But when we first looked at the data, that looked like it was a more significant trend until we adjusted for blood pressure. And what we found is that there was about a 10% reduction in GFR on treatment of blood pressure in this trial. And really, it wasn't much different between the different blood pressure lowering drugs and largely accounted for by the blood pressure lowering itself. So lowering blood pressure reduces your GFR. You couldn't pick that up unless you had direct comparisons with other blood pressure lowering drugs. This is data that doesn't yet appear anywhere, and this is from one of the data tables. And you can see here the baseline EGFR, the follow-up EGFR, the change in EGFR with all of the 3 active drugs. And then this is the adjusted change for the blood pressure differences, still slightly higher, but this was not significantly different from each other, and all of them produce a significant reduction in GFR, which is related to the blood pressure lowering by and large, whereas placebo does not, because that doesn't lower blood pressure that much. Finally, the renin profiling. This is the distribution of renin throughout the trial. Remember that renin was measured on a background of A plus C plus D, so we would expect renin to be predominantly elevated in these patients, and yet we saw a very large number of patients with what would be considered to be relatively low renins, consistent with the idea that there was sodium retention, but perhaps a lot of undiagnosed primary aldo as well, despite the best efforts of everybody to try and detect these cases. We saw a clear dose response between spironolactone and plasma renin, which was inverse in its relationship. So the lower the renin, the better response to spironolactone. We didn't see the same dose response with the other drugs. And the other drugs only began to overlap when renin was really quite high, very high in fact, did we begin to see an overlap in response. So spironolactone was not only the best drug, it was the best drug across a wide spectrum of plasma renins, many of them plasma renins that we don't often see in our patients with resistant hypertension. So in summary, we demonstrate for the first time that spironolactone, 25 to 50 milligrams a day, is overwhelmingly the most effective drug treatment for resistant hypertension. Spironolactone controlled blood pressure in almost 60% of patients, but in many ways that's an underestimate because we were close to control in almost all of the others, and was 3 times as likely, once you've adjusted, to be the best patient's drug, the patient's best drug versus bisoprolol and oxazocin. And at the end of this trial, if you were to look at the achieved blood pressure and ask how many of them would now go into a renal denervation trial where you had to have a blood pressure, say, of 150 on home blood pressure or 160 in the clinic, we would have had only 15 patients left who hadn't achieved that level of control. And we still may not have optimized treatment in relation to the dose of spironolactone. Spironolactone was well tolerated, with no significant excess adverse effects, with the caveat that serum potassium levels and renal function should be monitored on treatment, and the treatment duration of 3 months in the treatment cycle was almost certainly too short to assess incident gynecomastia, of which we saw none. But observational studies, including Ascot, another one from Denmark, have suggested that this approximates to 5 to 6% in men over a longer duration of treatment. So we need to look out for that. But basically, the biochemical profile was safe, and it does look like 3 months is long enough to see potassium changes, maybe not sodium changes. Pathway 2 is the first randomized controlled trial to directly compare spironolactone with other active blood pressure lowering drugs in a very well characterized population with resistant hypertension. Button's not working again. The results in favor of spironolactone is unequivocal. Spironolactone is the most effective treatment for resistant hypertension, and we believe these results should influence treatment guidelines globally. And finally, we also believe that perhaps patients should no longer be defined as resistant hypertension or indeed refractory hypertension unless their blood pressure remains uncontrolled after treatment with spironolactone. And like everybody else, we'd like to acknowledge the patients, all of you in the room, the investigators who made this happen, and the funding that we achieved. And we always make a point of emphasizing that all of these people who've made a major contribution to the trial are acknowledged in the Lancet publication. They're included in the supplementary material and will be linked to Medline and therefore acknowledged as an author and a contributor to this study. Thank you very much.
Thank you very much. This is open for questions. While just gathering thoughts, just one question, a very interesting comment about redefining resistant hypertension, which seems very one of the points I was wondering about, you mentioned at the beginning the use of amiloride, and I wonder if you have any data on that.
Well, we do have data. It was open label. We've had a quick look, and if you look at the low-dose amiloride, so they started, well, it's not low-dose, but 10 milligrams, and then the recommendation to increase to 20, not as many as we would hope, because it was open label and sort of voluntary, didn't go up to the higher dose. But certainly at the lower dose, it looked quite comparable to the lower dose of spironolactone. But we need to do that analysis, and I think it'll be a useful supplementary paper and potentially pilot data for a future study to see whether spironolactone is the only diuretic that does this, or whether in fact we could achieve the same with other higher doses of diuretic.
Okay.
The average blood pressure before add-on treatment was about 150 millimeter of mercury systolic. Frankly speaking, I don't see a lot of these patients. What was the distribution of the blood pressure for patients with higher end of the spectrum, where the starting blood pressure would have been 160, 180, or even higher?
I haven't got a slide of the blood pressure distribution. It's a good point. It's something we need to look at. But I think you've got to remember that these are home blood pressures. So a home blood pressure of around 150 is fairly substantially elevated in patients who are already on at least 3 drugs. And therefore, there's no doubt these people would be classified as refractory or resistant hypertension. The other point is, you're right, you don't see a lot of these patients. It wasn't easy to find these patients. And I think the teams did a fantastic job identifying over 300 of them who are well characterized. So it is a diminishing population of people with better understanding of how to treat people properly, but I think they still represent an important cohort, and I think some of the data that we get from the analysis of mechanisms may provide us with opportunities to design studies that maybe look at the use of these drugs like potassium-sparing diuretics earlier in the treatment regimen. That might actually prevent the emergence of resistant hypertension in many patients. Maybe part of the problem is the underuse of diuretics, partly driven by an attempt to reduce the metabolic consequences, which Maurice will talk about in the next presentation.
One question over there, then one question here, and then one question here. Get that gentleman on the left at the back. Thank you. Oh, yeah, okay, carry on if you've got the microphone.
I wonder if you have looked at the racial distribution of your population and whether you found that there is a difference in the response to spironolactone. I work in an area in London. I run the hypertension clinic where 30% of the population are Afro-Caribbeans.
Yeah, so we've been asked that question. We do have some Afro-Caribbean patients, but not many. And actually, the racial makeup or the ethnic makeup of the population is predominantly white. But we will look at that in more detail. I don't think we'll have power. Although the American studies, and David, if he's in the audience, maybe comment on this, the American studies have suggested, if anything, the response in black Americans was even greater to spironolactone than it was in the rest of the population, perhaps reflecting the fact that the sodium retention component is even more significant in that population.
Bryan, over here.
Simon, yeah.
You mentioned in your description of the study design various other methods of assessing adherence. Do you want to say a word about that?
Yeah, so we did three things. Obviously, the directly observed therapy was quite important. I think we lost about 22 patients whose blood pressure fell precipitously when they actually took the drugs. We then, throughout the trial, did tablet counts like most people would. We also measured serum ACE at baseline. That would allow us to see whether the ACE level was going in the predicted direction, depending on whether you were an ACE inhibitor or an ARB. And we haven't yet presented or published that data, but that data is consistent with very good compliance with therapy at baseline. And the final thing we did towards the end of the study, and we do mention it in the paper, but we haven't presented any data, is because we developed this assay at Leicester to do urine drug metabolites, we did actually incorporate that towards the end of the study. And again, without prejudicing any future presentation or publication, that data also suggests that we had very good compliance in this study. Remember, we didn't want patients to start adjusting therapy. 12 weeks was the rest of the therapy remained constant, which has been a problem in some of the other trials with turbulence in treatment. But we are fairly confident that our compliance with treatment was very good in this trial.
Just a question over there.
Thanks for that. The addition of spironolactone had such an impressive effect on top of the A group. Did you actually measure aldosterone in these people?
Yes, we did. So we've got plasma renin levels, we've got plasma aldosterone levels, so it's going to be very interesting to see whether there was any relationship between the response to spironolactone and the level of aldosterone. We will look at the aldosterone levels in relation to renin to see whether there might be some patients out there that we might have missed with primary aldo now that we've got better methods to detect tumours in these patients. And of course there'll be some with a high aldo and a high renin with secondary hyperaldosteronism as well for a whole variety of reasons. So I think there's still a lot of work to do in terms of looking at some of these baseline predictors and the relationship between some of the other neurohumoral effects.
We're just going to try and fit in a couple more questions, then to Peter.
Yes, coming back to the ACD and the underuse of adequate doses of thiazides. I mean, the Americans will criticize this paper and say that because in the UK we use low-dose benraflumethiazide, we're underdosing. I just wonder whether you've actually looked at the background thiazide therapy to see whether different doses of thiazides as background therapy influence the subsequent response to spironolactone.
It's a great question. We've been doing a lot of analysis at the moment. These are a lot of very good ideas for us to pursue. The majority of patients were on benrafluozide because when the trial was designed, that even predated the NICE guidance, which recommended clothalidone or indapamide. So I doubt there are very many, almost certainly there are no patients on clothalidone, but there may be some on indapamide, the later recruits into the trial. And we can look at that. But I think your point is well taken, that, and I think, I've already spoke to Bill Cushman, and Bill was saying about the SPRINT study that, they used, they pre-specified preferred use of clothalidone, which they think was one of the reasons why they were able to achieve such good levels of control. And they also used a lot of aldosterone antagonists in the treatment strategies. So their data is consistent with what we found, that these are very good strategies for getting blood pressure controlled in difficult patients.
Thank you. So we have pathway 3. So I've just going to finish off that question, then Adrian, question at the back, and then we'll move on to pathway 3.
Did you exclude people who had low sodiums and high potassiums prior to putting in the study? Because I use a lot of spironolactone and I have a problem with those. Also, you showed potassium data but no sodium data, and it's usually sodium that I run into problems with, low sodiums on spironolactone, and then only at 25 milligram dose.
So it's my experience too that with spironolactone, you know, the panic has always been about the potassium, but you usually get a good steer on potassium very early on. And it's actually the problems with hyponatremia later on that you sometimes see in these patients. We basically randomized patients as long as they were within normal limits within potassium and sodium. The specific numbers are in the paper. But, you know, your point is well taken that as this becomes more widely deployed, clearly some patients will develop hyponatremia on treatment. But, you know, I don't think that should be preventing us from deploying what is a very effective therapy, because the vast majority of patients will tolerate this without any problems at all.
Right, thank you very much. Thank you very much, Bryan, indeed.